بسم الله الرحمن الرحيم. أبنائي طلبة المستوى الخامس، اليوم هنتكلم على الموضوع الثاني من الكلينيكال يورولوجي. كنا اتكلمنا في البرزنتيشن الأولاني على الكلينيكال برزنتيشن of the urology patient، واتكلمنا على symptomatology and how to examine each part of the urology system in details. I hope we have revised that topic so as to continue with the second topic. Today we are talking about the investigations in relation to urology. The investigations in relation to urology, we shall talk about three things really. Number one is the urine analysis, which is very precious. We could call it as the mirror image of the kidneys, but the body, a healthy status. Number two, we shall talk about the urology-related blood tests, like simply the complete blood count, the kidney functions, metabolic workup, if there is any insult to the kidney secondary to this metabolic activity, or tumor markers, like the testicular markers, like the prostate markers. And number three, the topic number three are the imaging techniques. That's to say, the radiology, the ultrasound, the angiography, the renal biopsy. We shall take those one by one really in the few slides. To start with, let us come with the urine analysis. Urine analysis is very precious, and if you know its value, it really will never hesitate to request it, but we had to interpret and what sample of urine we need to request for our patients. Is it a morning sample? Is it a midstream sample? Is it a terminal sample? It is initial one. Let us see in the coming slides we shall see. By urine analysis, we will have a lot of data. Number one is the osmolality or osmolarity of the urine. Number two, we'll have a figure about the pH of the urine, which is normally acidic, but in certain physiological situations, it might jump up to an alkaline status. If there is any urinary red blood cells, white blood cells, or urinary casts, and by cast is meant here, it's very critical, those casts, if it is in the urine, there could be a pathological insult to the kidney taking the shape of some tubules. We are talking about some crystals. And if we are asking about the crystals, we are talking the urolithiasis and what type of the crystals we are having in this urine so as to treat it according to the type of the crystals in there. We will have an idea about the bile salts and urobilinogen in the urine. We will have an idea about the sugar, if there is any, about the protein, about sodium, about calcium, and some other metabolites in some of the metabolic diseases or suprarenal tumor. We have, a figure about an idea about the ketone bodies in the ketoacidotic patients, in the diabetic patients. We could see some of the bacteria, if there is bacteriuria or some parasites or some ova, like in Schistosomia hematobia. We could see some of the hematobia ova in there. Most of the urine analysis currently is being done by the what is known as the dipstick, exactly in this picture, which you could see in here. Just and each color of those colors, just in front of it, there is a certain number to give 1 plus 2 plus 3 pluses, and for each of them, it means something to be interpreted. We shall explain this in the coming slides. For the urine is formed in the kidneys, and it's a product of ultrafiltrate of the plasma, and this is done by what is known as the nephron, the functional unit of the kidney. As we know, we could have about 2 million nephrons in our kidneys, and this is being done ultimately. The urine will come out through the passage through the different parts of the nephron, then the renal tubules, and ultimately the urine is coming out through the urethra. This is just a picture of the urine in here, and this is the normal color of the urine. Let us say a little bit uh, not by this darkness being yellow. It's called an amber yellow coloration of the urine, and the odor is aromatic due to the volatile fatty acids in the urine. There is a foam whenever you are shaking the urine. Specific gravity, just keep the figure 10, 15, 10, 25, 1.015, 1.025. The pH of the urine is acidic mostly, is 4.6 to 8. If it is some, even by vegetables, it might come to an alkaline status. You know, sometimes there are normally traces of the urine. Of course, as we know, the urine is mainly formed of 95% of water, zero point zero 0.05 ammonia in there, sulfate is there in a certain percentage, chloride is there, uric acid is there, creatinine is here, sodium. So it's some traces which you could normally being accepted in there. But each of the substances is having, for each kidney, and each kidney is having a normally threshold for certain substances, like the sugar. There is a threshold. Above that is threshold, the urine could be coming, that substance could be coming out in the urine. You know, this is a picture of the nephron, and as if you, as you know, the glomerular here, the functional unit, the nephron is the functional unit of the kidney, and the parts of this nephron, number one is the glomerulus, which is being situated in what is known as Bowman's capsule. And due to the pressure in the Bowman's capsule, in the glomerular filtrate, and the afferent arterial blood pressure of this glomerulus, there is an afferent and there is an efferent in there. According to the blood pressure, which supposed to be just above about 60 or 70 millimeter of mercury, so as to give its own function. The main function of this glomerulus is the filtration of the urine. Then coming down, filtration of the plasma. All the needed substitutes like water, like glucose, like amino acids, all be filtrated in there. And ultimately, those will be reabsorbed in the proximal tubules, facultative. You know, by this is uh, by this arrow, as you can see, we can here is the green one is the passive transfer of substances like the water, like the glucose, like the small molecular albumin, and here it is an active sodium potassium pump in there, so as to let it be actively being reabsorbed to keep the normal balance of homeostatic function. So this is the glomerulus. This is the proximal convoluted tubule coming down to the descending limb of loop of Henle, and this is the other ascending limb of Henle. And here a big function for this loop of Henle. This if passive transfer of water out and the sodium being actively transferred out. And on this loop of Henle, some other drugs, mainly the Lasix and others, could be working, like diuretics, I mean. Then coming the ascending loop of Henle, by ascending loop of Henle here, there is a distal convoluted tubule. By distal convoluted tubule, it will be attached to the echolectic tubule. If we follow the osmolarity of the urine fluid passing through these tubules, ultimately we are having a progress in concentration of the urine, and ultimately we will have a concentrated urine with an acidic pH character. We had to mention in here that in this area near the proximal convoluted tubule and juxtaglomerular cells, we have the juxtaglomerular apparatus which is giving working on angiotensinogen and angiotensin system. You know, this is very important in cases of physiologically either, and to treat cases of hypertension, and the drugs could be working on this issue. This is just to review the functions of the nephrons, which is very important. Now, coming to the urine, and let us see the urine being formed of what exactly. As we mentioned before, about 95 to 96% is water. 4% are dissolved solids, and 2% of this is mostly urea. Half of it is urea. Then the other half, 2% of the components in the urine, other compounds, part is inorganic and part is organic. And the organic is there, creatinine and the uric acid. But the inorganic ones, we are having an ions like chlorine, like sodium, like potassium, and the traces of some amounts of bicarbonate in there. How to collect a specimen of urine? This is a very important question because not simply, not to ask for any patient, please go and do urine analysis. No, it depends on the state why you are requesting. Yes, randomly, you can ask for it random anytime. But in the morning, it means something. In the how to collect it. If you are looking for some electrolytes like calcium, you could need a 24-hour collection of urine. So for for urine request according to the status of the patient and why you are requesting that. So there is the routine or random sample just to give you enough idea about the urine status. A qualitative, if you are looking for a qualitative type of urine, you are looking for the morning sample, more concentrated urine. First voided urine is common really in the morning urine, and mostly concentrated urine for the cells, for the substances, and to give good answer for that. If you are looking for a quantity of the substance in the urine. You need to collect it 12 hours or a 24-hour sample of urine and for a quantitative estimation of like of protein or a valine mandelic acid, a metabolite of epinephrine, or you will 5-hydroxyindole acetic acid, or and metanephrine if it is a threshold is very high. And for in tuberculous patients, if you think of that like surgical TB of the kidneys, if you could ask for acid fast bacilli in the urine, so as to stain it by the Zillnelson stain, as we know, to detect microalbuminuria and some electrolytes. So you need here in those clinical situations a 12 or a 24 hours collection of urine. The patient will put some container just beside his bed and collecting the urine whenever passed and collecting 12 hours or a 24 hours. A clean catch test. By a clean catch here, if for a patient who cannot collect urine himself, and this is very important to have non-touched or non-contaminated urine. Like any children, you put a bag. Like in this child, we are putting a bag, a clean catch, so as urine will be passed in here to take the specimen for culture and sensitivity. Sometimes by suprapubic aspiration in a fully bladder, we can do that, but not always we like this invasive maneuver, but at least you can collect it in here for a proper culture and sensitivity. Postprandial in the diabetic patients, blood sugar, it's very important just to collect and, to get for blood sugar. For the preservation of the urine, not always the laboratories are ready to examine all elements in the urine just on the spot whenever you are giving it. So sometimes let us see how they are managing and doing. Collected urine need to be examined within 1 to 2 hours of collection, but can be preserved as in a refrigerator up to 8 hours. This is important. Let's see how laboratory technicians are doing. Adding thymol to prevent bacterial overgrowth to know the exact number of colonies in the bacteria, so as to judge properly what is the number of organisms in this specimen of urine, so as to give a treatment or not to give a treatment. For adding formalin, formalin will fix the cells so as to stain it later to see the types of cells. Even neoplastic cells, malignant cells could be examined in there. Acid or base addition to it so as to preserve the compounds which are expected to be in the urine. So how to preserve the urine is very important. The cell it has to be known by the technicians. Coming to the pH of the urine, which is ranging between 4.6 to 8, and this reaction could be acidic, as we know the urine, if in a ketoacidotic patient, on a starvation, or in cases of fever and dehydration. In a systemic acidosis, the urine could be acidic more. In infections with E. coli, and some other gram-negative bacilli, it can do that. Acidic urine. Acidification therapy like ammonium chloride, some patients used to have some like herbal medicine or whatever compounds, and it might cause their acidic urine. So it's important to ask your patient if he is taking anything or she is taking anything. Alkaline urine will be found in strict vegetarians. نباتيين الناس النباتيين they are having this alkaline urine. Systemic alkalosis in one of the diseases. Very important, the proteus infection in the eye. Very important to note that. There is a big number of colonies of bacteria in the urine. The infecting organism could be Proteus, and it's important to start your antibiotics, even to start with empirically. Then, on the basis of culture and sensitivity later, alkalinization therapy can be a cause of this alkaline urine. Of course, urine could be tested by litmus paper, by dipstick paper, by pH paper. It can be. Examining the urine, it had to entail five things. Number one, macroscopic examination of the urine, then microscopic examination of the urine, then chemical examination of the urine by dipstick, then culture and sensitivity for this urine, then coming to the cytology of the urine, what types of cells you are looking for. So those components of the urine analysis you are looking for. For microscopic, we are looking for the volume, for the color, for the odor, for the action, or urinary pH, the urine and the urinary pH. Come to the specific gravity of the urine. It's very important, specific gravity breakdown of tissues or, plenty of the clinical situations we have change of once. The urinary volume normally, as you know, the normal adult person is expected to have urine output ranging from 1 to 2 millimeter per kilogram per hour. And this is very important. For, less than zero point 0.5 milliliter per kilogram body weight, we'll call that oliguria. So the normal adult is expected to exceed from 600 to about 1.5 liters a day. In polyuric patients, if this amount is about 2 liters, and we could find this in diabetic patients, diabetes insipidus patients, in polycystic kidney patients, in potential failure later on. It's very important with the patients having diabetics uncontrolled diabetes. So, this is very important. Or overhydrated patients on the post-operative status of in some patients. In oliguric patients, less than 400 milliliters of urine, and this could be faced during dehydration, vomiting, diarrhea, excessive sweating, renal ischemia, ETN, acute tubular necrosis, or obstruction of the urinary tract. But bianuria is complete cessation of urine. When the patient is secreting less than 200 milliliters, so let us, this is a serious sign. Let us look for the kidney, what is going wrong in this kidney. Nocturia, which is by nocturia is meant excretion of urine by an adult, less than 500 milliliter, with a specific gravity of less than 1.118 at night, and this is characteristic of chronic glomerulonephritis. So just by knowing the amount of the urine, the duration, and when does it happen, it's very important for us to know so as to judge on or to think of certain disease for the kidney. Looking at the color of the urine, the normal color, as we said, it's an amber yellow, clear, colorless dilution. If it could be color, a colorless urine, if diluted in diabetes mellitus patients, in diabetes insipidus, milky purulent in genitourinary tract infections, chyluria, could be orange in some fever, breakdown of tissues are there in the urine, excessive sweatings, could be red if beetroot ingestion or hematoric patient, a brown or a black in alkaptonuria. In alkaptonuria, you see melanin pigments could be giving the color of black urine, and so think of that. Odor of urine, normally it is aromatic due to the volatile fatty acids or ammoniacally due to bacterial action, but it's fruity in cotinuria, and this is very important. If you are thinking of some patients having diabetic acidosis, you can smell the urine like fruity urine. Specific gravity, as we know, it is a reflection about the status of the urine. If it could be increased, and in oliguric patients, increased All cases causing oliguria, like in a dehydrated patients, in heart failure, in a diarrhea patient, in glycosuria really in the urine, or in a syndrome of inappropriate antidiuretic hormone secretion, SIADH. Very important to know that this is could be a triggering sign to think what is going wrong in this patient. And decreased pH could be decreased with specific gravity, all causes having a contrary to the increased specific gravity. There it is oliguria. Here is polyuria, except in glycosuria. And the clinical conditions, ETN, acute tubular necrosis, diabetes insipidus, drinking a lot of water, or kidney failure, or a chronic renal insult. For in biochemical examination, we are looking in the urine about proteins, albumins, Benz-Jones proteins, which could diagnose multiple myeloma. We are looking for sugars, we are looking at kidney bodies, bilirubins, bile salts, urobilinogen, and the blood. This is biochemical examination, and this is simply could be done by the dipstick. No need to just to keep this in mind, but to know what the dipstick can give us answer for glucose, for bilirubin, for ketones, for specific gravity, for the blood, for pH, for the protein, for urobilinogen, for nitrite, for leukocyte esterase, and each color of those could be discolored if there is excessive amount or pathological amount of such substances in there. You know, this is a nice and very important table, looking how much you are to keep the dipstick in the urine to have to be ready to have a result, a clear result. Say here we are talking about glucose and bilirubin. It had to be in there for 30 seconds, but for ketones it had to be there for 40 seconds. But looking for a specific gravity and leukocyte esterase, it had to be 2 minutes in addition to pH. If leukocyte esterase and pH and the specific gravity had to be in there for 2 minutes. For the blood, if looking for RBCs, you are to look to keep it for 60 seconds. For the protein, it had to be 60 seconds. So it is not only just putting it and come out at any time. No, if you are asking for something, so keep it in urine for this assigned timing so as to have the clear result and correct result of your reading so as to be correlated with. And those are the colors, but just have an idea about it. For microscopic examination of the urine, a general aspects to consider really. How to, as we said, the urine had to be preserved, say in formal diet for the cells, for in, acidotic or alkalotic media, so as to to examine it in and to have the correct result. So cells and cuts being to disintegrated in 1 to 3 hours. So before that, you are to examine it at normal temperature. So on refrigerator, it could be accepted. Refrigerator up to 48 hours can do. So have an idea about it. The concentration of the urine, 10 to 20-fold concentration by centrifugation. Urine is centrifuged so as to give the results and to know this is a centrifuge system and to be examined on that basis. Type of microscopy, we are having the phase contrast microscopy, polarized microscopy, a bright field microscopy with a special staining. Just have an idea about it, not essential, very essential for us, but as physicians, really, we'd like to stress the point we are to know how our technicians are working so as you know to be very fluent in discussing with them the results. And by microscopic examination, we are looking, there is something, white blood cells or RBCs in the urine are always given by numbers per high power field or per low power field. If we are talking about per high power field, high power HPF, that's to say it is magnified up to 400 times the specimen, the microscope is magnifying. If there is more than this is pathological, it is more than 3 erythrocytes, more than 5 leukocytes, 2 renal tubular cells, and more than 10 bacteria. Those are pathognomonic, pathological, I mean. Or if if we are having measuring by the low power field, that's to say, magnifying by more about 200 times, and there is if there is more than three hyaline casts or one granular cast or more thin squamous cells, because sometimes physiologically less than that will be disquamated the cells inactivated by contaminated specimen. Any other RBCs or it had to be commented. Presence of fungal hyphae, we are to look for that. Hyphae fungi are having a specific character, or parasite or viral inclusion to be, it will be seen microscopically. Pathological crystals like cysteine, like leucine, like tyrosine, like number of uric acid or calcium oxalate. Those are crystals. You know, if we're talking about stones, you are looking for crystals, as we mentioned. For erythrocyte, we are to differentiate or to know the dysmorphing from the normal ones. Dysmorphing more than 10 per high power field pathological. Leukocytes, neutrophil, glittered cells, and this is more than 1 per high power field. Still, this is pathological. Eosinophils, Hansel test, which is a special stain. It's a special stain. By epithelial cells, squamous cells indicated some contamination while collecting the specimen. Renal tubular epithelial cells, few are normal. Transitional epithelial cells are few are normal. I mean, less than two or less than three will be accepted. 5 to 3 is accepted. Oval fat bodies abnormal indicated nephrosis like the nephrotic syndrome. Very important. If we see some fatty cells, think of nephrotic insult, especially in the. Let us have some microscopic picture in here. Those RBCs are biconcave cells. Better to have just an idea about the normal RBCs, which has been, in addition to some dysmorphic ones. This is the biconcave discs of the RBCs. This is very clear picture for the RBCs. For the RBCs here, the dysmorphic, more and more clear than the other ones. This is the biconcave typically, and this is the dysmorphic ones. Have an idea about it. And I advise whenever you are in the hospital, go to the lab, see some of those pictures, which will be very uh, precious. Looking about the the white blood cells, macrophages could be in there. Different types or different cells of white blood cells are in here, and this is fairly an indication for UTI. Here there is a hyphae, something like even fungal infection, in addition to the white blood cells which are in there. Those are squamous cells being shedded according to the amount, no neoplastic, not neoplastic, but there are some squamous cells there in the urine and something to report in there if it is contaminated, at least tubular epithelial cells, and there is, if concomitant with the cast in there, could be indication for some damage or uh, tubular pathology if there is a tubular, but at least this is the cut section in the tubule and giving the normal structure of it. Transitional cells shedding out transitional cells of the bladder or the renal pelvis, or we can see this is normal in some of them. Those are again transitional cells, oval fat body cells, and this is very pathognomonic, very important in nephrotic syndrome. Oval fat body is very important to know. This is very pathognomonic for some other diseases like symptoms. Leukocyte esterase cells, very important to see. This is the nucleus, one of the white blood cells, very clear, stained in a very nice way, and just part of it being affected. And one of this is for cytological neoplasms of the kidney or the ureter or the bladder or the prostate even. We can see the cells, cytological examination of the urine. Papa Nicolai stain, rice stain, immunoperoxidase stain, or immunofluorescence stains. Those are the stains which could stain the urine. Very precious, the urine, really. Here, this is the normal shedding out of the transitional cell epithelium of the bladder, becoming reactive more and more cells without being no change of the chromatin ratio to the cytoplasmic ratio with no characteristics of malignancies is there. The COI cells here, the immunoperoxidases in polyoma, and this is very pathognomonic and very important if you discover that. Just give hint from the you can diagnose something. Transitional cell carcinoma, low grade change of malignancy in here. change of chromatin-like substances. Malignant changes are there compared to the normal ones. Some cells are there, so there could be some here high stain, high grade of a transitional cell carcinoma, and this is carcinoma of either the renal pelvis or the ureter itself or the bladder itself or even the urethra transitional cell carcinoma is the squamous cell carcinoma could be a bladder tumors. One of it is could be squamous cell carcinoma, and just it is in there and giving the picture of of squamous cell carcinoma. Anyway, the idea from those slides or from this presentation is to see that cytological examination of the urine is very precious to give an idea about the pathology going on. This is again renal cell carcinoma showing us the malignancy, the neoplastic chromatin-like substance, loss of the normal characters and loss of polarity in there, uh, giving an idea. About prostatic carcinoma can be there, prostatic cells and just invading, and some of them has been shedding to the urine and giving the picture, typical picture of carcinoma of the prostate. Just for clinical scenarios, let us have from the urine itself. Let us have an example in this case. A 35-year-old man, 35-year-old man, undergoing routine per employment drug screening, like بزمثيل الكوميسيون الطبي يعني. Physical examination characteristics are clear. A microscopic examination is there, is not performed really, but a drug identified, no drug has been identified. And this is the dipstick of this patient. Glucose is negative, bilirubin is negative, ketones are negative, specific gravity 1.001, blood is negative, pH is 5.5, a protein is negative, urobilinogen within normal still, nitrite is negative, leucine is still. So what is abnormal in this patient, you think? And how to make sure if this patient is having a disease or you need to do something else. I think whereas all of those are negative, except one here, which is the specific gravity. And here, what to do for this patient? What is the next step on this patient? Let us go and see the next slide, really. What do you think it could be before seeing the next slide? The next slide will ask you to do this morning drug urine analysis, more concentrated urine, get the specific gravity will come to its normal. He could be overhydrated and coming and going there, physiological. So diluted urine could be a request. But if this morning sample is still diluted urine, so think of something else like diabetes insipidus in this patient so as to make sure he is okay. Otherwise, if it comes normal, so from the urine analysis, you can come up with a certain diagnosis and very simple, the least costing investigation. Really. In this another patient, we are having a 42-year-old woman with a dark urine, physical characteristic, red brown, dark, tea colored, say, and microscopic examination not done. Let us see if we need it or not. Let us read how this is the dipstick is saying. Glucose is negative. Bilirubin is 3 plus, so big amount of bilirubin is there. And discoloring the urine. I think you came to something now while reading this. Ketone is negative. Specific gravity is 1.020 and this is normal. Blood is negative, so the red brown is not blood. pH is within its normal range, 5.5. Protein is negative. Urobilinogen is within normal. Nitrite is negative. Leucine esterase is negative. No infection. No. So what could be mostly the diagnosis or differentially the red brown urine with the three pluses in here and the dipstick, and all are within normal ranges, the other references. So there must be some sort of hepatobiliary problem in this patient, isn't it? Let us see. The answer is possible gallbladder hepatic disease, no hemolytic anemia, no blood, bilirubins in the serum. You can make sure that this patient is really jaundiced, say, so we are to request for a blood bilirubin total and direct bilirubin. microscopic is unlikely to give us any additional information because why to do this? So even so as not to complicate the life of your patient, you are to the point. This is the last case clinically I'm talking about. A 42-year-old man presents with painful micturition. Whenever passing urine, very painful micturition. By physical characteristics of the urine, it's dark red, turbid, microscopic leukocytes. Wow, 30 per high power field. It's high. RBCs are more than 100 per high power field, and bacteria is more than 100 per high power field. So, what do you think this patient could be having? Let us come to the depisted. Sometimes we are more. Once you have those findings, an idea came to your mind. Make sure how things will be. Glucose is negative, bilirubin is negative, ketone bodies are negative, speaking specific gravity is 1.030, a little bit higher, but accepted. With this picture, I mean, the blood is plus, 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 three pluses. pH is 6.5, acidic urine. Protein are traces. Urobilinogen 1.0 milligram per deciliter. Nitrite is negative. That's to say this infection is not protease cell. Because if it is nitrate, it might be alkaline urine. The equinocerase is plus, plus, plus. So the white blood cells are high. Going to the so what could be the problem with this patient? Definitely this patient having some sort of UTI, requesting what to do next step. This UTI, do culture and sensitivity. If the patient is feverish, please start empirical antibiotic and then do the culture before just the start of the antibiotic. Negative nitrates means gram-positive bacteria is the insulting organism here. So you can give some antibiotic. Low specific gravity may show less number of cells, uncommon in this type of patient really. The idea is I like you to know that the urine is very precious in giving a clinical decision. Please have a break and come to the next type of modality to diagnose renal diseases. So the next modality to diagnose renal diseases, simply you are to start by the complete blood count, and if you know this patient is hematuric and lost some blood, you need to know the hemoglobin level in this patient. As simple as that. Look at the bleeding diathesis in this patient. If this patient is having hematuria, as in on aspirin or coumadin or anticoagulant or bleeding diathesis have to be worked up. Blood creatinine and urea. Creatinine is more accurate than urea itself because once creatinine has been secreted or came out with the urine coming out, urine being formed, it will not be reabsorbed. But the urea, once secreted, it could be absorbed in the distal. So creatinine is more accurate than urea. Look for uric acid if the patient is having some sort of uric acid crystals, but not necessary for any patient with uric acid crystals or stones to have high uric acid. It's a metabolite problem, but at least to have an idea about it. You are to look for parathormone and calcium level. If the patient is having some sort of nephrocalcinosis or a stone passer or recurrent stones every now and then. So look for the parathormone pathology and the metabolism of vitamin D and calcium levels, whether being normal or not normal, the total ionized. Look for the vitamin D and see if there is any disease or then even metastatic disease could be a leading, metastatic disease could lead to hypercalcemia. This is very important, really. Blood albumin. Albumin is having a relation direct with the calcium levels. Uh, Look at if there is a prostatic problem in your patient. Look for the PSA, prostatic specific antigen, or acid phosphatase in the cancer prostate. Let us look for it. Tumor markers like the alpha fetoprotein, the beta human chorionigoproteins. Some testicular. So blood diseases are always precious investigations to the patient, but please always request what is your case related. If related to humor, request the specific investigations for each patient, not just that list and give it to all patients. No, of course, I know, but just I'm stressing this point. The third modality, which is very important, very precious to give a diagnosis about the diseases of the urinary system, is the imaging techniques. And by imaging techniques is meant the radiology techniques, the ultrasound techniques, the magnetic resonance techniques, the angiography techniques, renal angiogram, and even the isotope scans. It is very precious. It can give a clear idea about the pathologies in the kidneys really in a nice way. Coming to the imaging techniques, number one, let us just enumerate and have an idea about it. Quantitatively, we could have a plain X-ray just to see a radio opaque shadow or an nephrogram or some shadow of a certain swelling or calcified. Plain X-ray is very important. Cystoscopy just through the scope, you are going to the through the urethra. Urethrocystoscopy, we call it. And this is very obvious to see the interior of the urethra, to see the interior of the bladder, the trigone, the ureteric orifices, the walls of the bladder. It's nice. If there is any tumor, any inflammatory process, you will see everything. Excretion urography, like what we call it IVP or IVU. We like calling it IVU, intravenous urography. Having an ultrasound, especially with the new definitions, the new generations of ultrasound, it's very precious and very important. But ultrasound is always an operator dependent. And that I advise you all just to have, to be trained later on doing your ultrasound yourself. It's a very simple technique, and as physicians or surgeons, we are to know how to do this ultrasound. Computerized tomography, it's very nice, especially by a multi-detector CT scans, a new generation giving very nice readings. Magnetic resonance imaging, it's very nice again. It is without X-ray, no exposure to X-ray, but it depends on the radio frequency of the hydrogen ions in the cells of the tissues, and on that basis it gives nice picture. Pyelography, which is could be antegrade, just injecting a dye from the kidney itself or a pelvis of the kidney, and the dye will go lower down. So we are calling it antegrade pyelography. Or retrograde, that's to say, injecting some dye from the ureteric orifice up the other way, contrary to the urine coming down. Micturating cystogram, just giving a dye in the bladder through a Foley's catheter, and then ask the patient to pass urine. To pass urine and look at you are in fluoroscopy. If there is some reflux of the urine while contracting the bladder, the urine will be refluxing to the ureters up. We are calling this micturating cystogram or cystography. Aortography or selective angiogram for the renal artery. It is both diagnostic and therapeutic because if there is stenosis in the renal artery, it could be dilated while going in. We shall see this in the coming slides. Renal scintigraphy isotope scan. Very important to see the functions or non-functioning kidneys before serious decisions in some patients. It's both static and dynamic, and each of them measuring a certain function of some parts of the kidney, whether filtration or tubular function. Or then coming to the big issue, which is very important, the transcutaneous renal biopsy to diagnose the chronic diseases in the kidney. Sometimes by examination, by all other investigations, we cannot reach a diagnosis, but by tissue biopsy from the kidney, we can diagnose that like protein loss or something. So look at this nice picture of a plain KUB. KUB kidney, a bladder, and ureter. I advise also to do, if a patient comes with acute retention, say urine, sometimes in the urethra in here, there could be a stone obstructing the urethra of this patient. So please do it according to the status of your patient. KUBU, urethra, I mean, even. But in this one, how do you look for this? This is a radio opaque stone, and always we are advising, as we have mentioned our lectures before, that look at the stone at the tips of the transverse processes of the lumbar vertebrae, at the pelvic brim, at the ischial spine, going to the bladder aorta. Here, at this line, you can see the possibility of a stone and the differential diagnosis for that. This is very important. If there is no gas or the bowel prepared where we could see a nephrogram, being dilated for this. So this is a radio-opaque stone in this KOB, and on that basis, I can diagnose. Even I can differentiate this is in the right hypochondrium. Is it gallbladder or is it renal? So to differentiate that, as we said before, take a lateral view. The gallbladder is laterally placed in front of the spine by the lateral view, but the renal stone or urethric stone just could be lying on the spinal bodies themselves. This is just it's cheap and important. For ureteroscopy or cystoscopy, as we see in here, this is the urethra. Through it is passing a scope in here. The scope is being passed to start with we are passing the scope with an angle of zero scope. Then if we are going to the bladder, we are changing the scope to 60, or according to the pathology, I'm going to the linear 30 or 60 scope. You know, by 60 or zero scope, the scope is a stainless steel tube. It will fit the catheter, the caliber of the patient's urethra to go in without causing any damage to anything, going very wise, under vision. This is straight. So in the urethra, zero is enough. But you would like, if you would like to see the lateral size and the dome of the bladder and the base of the bladder, you need some angle, and the angle, the scope, like 60 or 30, gives it better. You know, here by the scope, you can see by your own eye what is the pathology in there. You can take a biopsy, you can dilate the bladder, you can do everything. It's very precious, really, this scope. We are calling it urethrocystoscopy. Urethra needs a zero scope. In the bladder, we are changing it to 60 and sometimes to 30 as to see ureteric orifice. Through this seeing of ureteric orifice, we come to the next stages like retrograde pyelography, if you would like to put a catheter and inject the through the ureteric orifice. Coming to the functional studies like intravenous or excretory urography, IVU, this is we are using a dye, and this dye is taken by the kidney tissues, and it has been largely replaced really by the CT scans and ultrasonography because this iodine containing dye it could be allergic to some patients. And very important to know, the patient must have normal kidney functions. Otherwise, by this effect on the renal cells, it might go sometimes a renal damage or renal insult. A borderline renal function tests, might be damaged after this study. This dye always had to be given, please, it had to be given by the doctors. Because if there is allergy, you will take an action. Before doing that, you will know that this patient is having normal kidney functions, and on that basis, you are giving a dye that will be excreted onto the renal tubules and see the functions. It could be, of course, delayed. And before doing this IVU, to start with, before giving any dye, take a plain X-ray to the patient, plain KUB, something like this. Then give the dye. Spontaneously, just after the dye, take one. Then after 5 minutes, another film. Then after 15 minutes, another film. Then after 2 hours, and so on. Sometimes the patient will not secret dye except after 6 hours or the next day of the study. So delayed films is very important still. It depends on the patient and the executive function of the kidney. Now to the ultrasound, it is very precious, better than X-ray, since avoids ionization and IV contrast, but it depends largely on the ultrasonographer. It shows the cystic and solid swellings. It shows the cortex, the differentiation between the cortex and the medulla. Cortex being functioning, not functioning, thinning, or, there is a stone. This ultrasound will show the radiolucent and radio-opaque stones, not like the X-ray stone, which is showing only the radio-opaque stone. Yes, mostly the renal stones are radio-opaque, 90% of them, but still uric acid sample, pure uric acid stones are radiolucent, and they are seen well by the ultrasonography. So it is used to measure the size of the parts of the renal system, check for the blood vessel diameter even of the renal artery and the big vessels, checking whether the masses or cysts are in there, solid or cystic, and their texture, measuring the perfusion, checked by the clots sometimes if it is in there. A disadvantage, it is operator dependent, as I said. It is lack of sensitivity. Sometimes, you will see, and a radiopicastone at the transverse process of the spine. It could be a shift of a fracture transverse. It could be calcified lymph node. It could be. So it's very important, to know the differential diagnosis of a stone in there so as to judge in a better way. For this, better to know advantages and disadvantages of all. There is Doplex. Doplex is very important tool. So as with the Doppler principle, ultrasonography and by Doppler is we can see the renal vessels, renal artery, and if it is a stenosis and renal vein, the caliber for that. It's very nice, really, the Doplex by the coming to the CT scan, especially by the multimodality CT scan, and as you know, the patient is being sectioned into sections, and it depends on the thickness of the section doing that. By the multi-detector CT scan, we are having very nice and delineated with a three-dimensional. Look at this three-dimensional by CT scan. Renal vessels are very nicely delineated and by 3D. Those are the renal arteries coming here from the aorta in here. This is the renal artery, and the renal vein is going in there. It's very nice. And the other kidney in here. It's very important, really, to do even in transplant instead of the conventional selective angiography, which is very invasive one. So, but the disadvantage for this one is for the CT scan is sometimes the huge amount of radiation the patient could be exposed is not too much, unaccepted for just one was, but to be considered in our mind. By giving a dye, we could visualize the arteries and the veins, structural findings, abnormalities, and the disadvantage, the main one is the higher doses of radiation. It's available in the country, the CT scan. Yeah, some centers. This is the magnetic resonance imaging, especially if you are injecting it by angio MRI of the renal system. Look at nicely how it is being delineating the kidneys and vasculature of the kidney. And the idea behind doing the magnetic resonance imaging is it is working by the idea is based on the radio frequency plus the return from a radio frequency stimulated protons in each excited tissue. And each tissue is having a specific number with protons in each cell. So it's very nice, this MRI. It will delineate the structure. It will tell you this is a muscle, this is a cyst, this is disturbed tissues like a tumor, like. So it's nice delineation, avoiding contrast. The big advantage, there is no advantage. We can see the vessels in a very nice way. Is you can say it is expensive, but it's available. Whenever it is available, still we are to do we are to make use of this. Ionizing radiation is there. It's very nice tool to diagnose. By antegrade pyelography, as we said, we know that the urine is coming from the kidney, going down to the renal pelvis, going to the ureters, to the bladder, to the urethra out. So if we are injecting dye proximally in the substance of the kidney, or in the renal pelvis, it will delineate really. It will delineate the renal system, but by just contrast, it will show the obstructing element, whether it's stone, whether it's tumor, whether, you know, uh, it could be done by either guided ultrasound or CT scan guide. The ultrasound will tell you here is the renal pelvis, so you can puncture that and put your catheter even. Sometimes we are doing the pyelography only or putting pyelostomy, putting a tube in there. It could be a treatment even. For a patient, a critically ill patient, to downstage the disease of the patient, you are doing this study, and keeping the catheter in there. So as you know, when improving the patient, you are to do the definitive surgery if there is a stone, if there is a tumor obstructing the pathway in one of both kidney or in one or the other kidney even, so as to come down in a better way. And by retrograde pyelography, here we are using the cystoscopy as well as mentioned earlier, urethrooscopy, and continue to uh, cystoscopy. See the two crescent-shaped ureteric orifices at the trigon with the main body, the junction with the trigon and the main body of the bladder, and see that opening, putting a guide wire to start with, then putting on it a catheter and take the guide wire out and just keep the catheter in there and inject some dye, radio opaque dye, so as to see the delineation of the. This is retrograde one. Sometimes we are keeping a catheter in there like the antegrade pyelography. We are putting a pyelostomy or nephrostomy. Here we are putting a double J or double J stent, we call it. Stent will be ending in the renal pelvis and the other end in the urinary bladder. And this will keep it draining. If there is stone obstructing, so you are bypassing the stone. If there is tumor still obstructing and the kidney obstructing, you are passing the stone. If there is infection, it will you are overcoming the infection. You are downstaging the status of your patient. It's very invasive a procedure, yes, but very precious for a patient who is in severe colic, who is severe renal derangement, and just putting this stent in between the bladder and the renal pelvis after injecting the dye, seeing the pathology, then taking the decision to put this catheter. It means a lot for your patient. This is rather than doing big surgery for the patient to remove a stone on emergency basis. This is very rewarding. Really. We are saying expensive, but nothing is expensive for your patient. Your patient deserves everything. For renal angiography, and this is the selective angiography, we are going through the femoral artery, one of the big vessels. Either we are going the standard, the gold standard is the renal artery imaging or renal angiography. Sometimes you are going through the femoral artery, reaching the renal artery. This is the selective one. But there is something called conventional or digital subtraction angiography. Just it's a nice machine, just delineating the renal vessels in a good way, mainly used to define the external or intrarenal arteries. Sometimes the pelvis itself is intrarenal. The renal arteries are very important to diagnose if there is a certain disease. The gold standard, as we mentioned for the renal artery, is the renal angiogram, usually indicated the prior to renal transplant in the donor. But transplant in the donor nephrectomy we are going to do because we are always trying to select the better manipulated kidney so as to come with the least damage to the kidney itself. And usually we like to take, as you know, the left kidney because the renal vein is longer than the right kidney. And the approach, yes, on both sides is more or less the same, but the renal vein on the left side is much larger and mostly we like it. Here, if in transplantation, we like to have from the donor the kidney with a single artery rather than any other aberrant arteries or a kidney with two arteries. Simply to make our surgery in the transplant for that patient, transplanted patient, we do one anastomosis rather than to do two or three anastomoses. That's why we like to have the kidney with a single artery. That's why it's very important to do a renal angiogram to see which kidney we are going to take from this patient, from that generous patient, uh, to donate his kidney to one of his relatives, spouses. For the micturating cystourethropy, in micturating cystourethropy, here we would like this is intended mainly to see the reflux in both ureters. How to do that? We are putting a Foley's catheter in the patient and injecting some diluted fluid with radio opaque material, and we remove the catheter after that, and the patient under fluoroscopy in the X-ray suite down, or in any hospital, we shall, observe the patient, or the fluoroscopy will give us the chance to see while the patient is passing urine. We are following and looking at the ureteric orifice and taking some pictures, some X-rays to the patient. If there is a reflux, we shall see that patient will, the urine will be, instead of going to the urethra, it will go to the urethra, and by that way, we are diagnosing the ureteric reflux in a nice way, really. Often, this is combined with the pressure studies to the different parts of the bladder and urinary system. But doing that, we are to keep in mind that the patient is not have significant infection. Otherwise, we shall have ascending infection to the kidney itself, and the professionals doing that procedure, they are to you know, uh, to do it in a perfect way, in a way or another, so as to give a proper result. Aortography or renal angiography. By renal angiography, this is the selective one. Look at this nice picture. This is through the femoral puncture, either in the right or in the right side, on the or on the left side, going to the aorta, and through the aorta, the catheter is going to the place, to the main stem of the renal artery, and trying, to inject some dye, and through this delineation of the vessel, it's nice looking. So if there is a stenosis in here, we could diagnose with this study, renal angiogram. If there is stenosis in here, diagnose. Soon what to do for the renal artery stenosis? So do some sort of dilatation or angioplasty. We call it like a renal angioplasty, and this patient could be having some sort of refractory hypertension in spite of a number of antihypertensive drugs. We call this type of renovascular. So we can treat. So we can dilate doing angioplasty. We could put a stent if it is diagnosed in here or there. But here the patient will be exposed to some X-rays. It is fairly invasive maneuver, but it's very rewarding. The patient could be diagnosed and have the treatment this way. It could be done by the say, digital subtraction angiography. Renal scintigraphy, this is by the isotope scan technician, the technetium, which is the isotope material. And this is of two types, this study. Through a gamma camera, we could have a dynamic study and we could have a static study. By dynamic study is meant to study the function of the glomerular filtrate, as simple as that. Keep it this way. By the static study, we are seeing the tracer will go to the renal tubules and we are looking for the renal tubular functions. We know each part of those segments of the nephron are doing certain jobs, and each could be measured in a nice way, the status of the function in them. So for the dynamic one, we are using the technetium 99 BPA, and this is excreted by glomerular filtrate, and some pictures are taken, and on that basis, we could diagnose. If you remember 1231, as the iodine tagged 1231 is both filtered and excreted by the tubules. It is not function for the tubule. It being excreted and to be filtered and secreted. Following various injections with the tracer emissions from the kidney recorded on a computer analysis. This is just not simple like in a picture, but computer interpretations and curves for that. We shall see a picture for it. Allowing the examination for the renal perfusion, glomerulofiltration, and transit through the kidney and outflow from the urinary tract to the bladder, to the urethra. Then sometimes there are false results for that, and this false negative. We are to know some is like this. So correlation with the clinical status has to be considered. But this is realistic physiological conditions. We are to know. This is a scintigraphy. Looking at this one with this is a normal one, and here there is a renal scarring. The dye or the isotope skin taken fairly with renal cortex and perfusion being perfused in the kidney. But here there is a scarring in the kidney. That's why at least there is no perfusion significant in this one. And by this one, this is the normal perfusion patterns of the curves. Let us just have a look. I like you just to have a look and to know the significance of scintigraphy in this one. Static scintigraphy, we said that we are intended to study the tubular functions of the tubular cells. And here, performed using technetium 99 DMSA, they call it, which is taken up by the tubular cells. Uptake is proportional to the renal function. That's why we could say that the function of this kidney is 25%. Function of this kidney is 75. GFR, glomerular filtration rate for this kidney is 1, 2, 3, 4. Or it is giving a real figure telling us or helping us to take decisions how to manage such a kidney which is being which having a certain level of renal function, which is very important, helping us to take decisions in our patients. Renal biopsy, the last but not least, is very important to diagnose some chronic disease of the kidney, like a protein losing enteropathies or some uropathies. Ultimate in the diagnosis or assessment of chronic kidney diseases, sometimes some patients are their kidneys, the patients are not diabetic, are not hypertensive, are not having metabolic problem, but still we don't know what sort of disease is having those patients. So it is not percutaneously under ultrasound guidance, the biopsy, but needs a professional to do it and the professional to read the biopsy. There is a specific certain histopathologist to read it properly, to interpret at least the renal biopsy. It's very important the renal biopsy for the kidney transplant patients is there if there is some sort of jeopardy or insult to the grafted kidney in that patient to see what sort of pathology is going on in this patient. It's very helpful, really, the renal biopsy, but needs a specific indications. Investigations for proteinuria, as we have mentioned, microscopic hematuria, diagnosis of rejection renal transplant, prolonged use. If there is renal failure, and still we don't know the cause, unexplained renal failure or systemic disease where the proteinuria is coming in. Thank you a lot. It's a long lecture, I know that, but it is very important, essential for us just to practice. Please ask me any question anytime. I am ready to answer in any time.